The title, although looks a little cutesy, happens to be exactly my opinion, and you'll see why in about 10 minutes. The other thing I should tell you that is really relevant to sort of my journey and where we are all going in the next 20 minutes is I grew up in a medical family. I trained in all the prestigious East Coast kinds of places, socialized at Yale and Harvard, that basically the patients are there for me. You know, the morning patients all showed up at 9 o'clock, or were told to show up at 9 o'clock, and you just saw them one after the other, and if somebody had to wait 3 hours, you know, that was okay. That was what I thought was normal. I took a job in a private practice. The people at Harvard, when I left Harvard and took this job in San Diego, went, "You're doing what?" It's a long story why I took the job, and I didn't realize how important it was that I took it. I took a job in a private practice, which also had this academic arm. It was the pediatric cardiology division of the University of California, San Diego, back in those days. But it was a private practice. You see the 9:30 patient at 9:30, okay? And if a referring doctor says, "Hey, I think this kid's got an innocent murmur, but I'd like you to look at him," and he's in a hospital 120 miles away from San Diego, your response is, "Oh, let's see, it'll take me about 2 hours, I'll be there. Yeah, it's midnight. What difference does it make?" Okay? You're there to serve. I began to like this. And I grew to appreciate a patient-centric practice. Okay, and we ended up with this large multi-specialty practice and et cetera, et cetera. And so it was very successful, and we all made good livings, and we did great research and blah, blah, blah. Okay. They recruit me to the University of Chicago, and here is where I'm just telling you my, personally, huge failure. They knew what they were recruiting when they recruited me. At least I thought they did. What they really were recruiting was a guy with a big, long CV, and I got a lot of research and a bunch of papers that I published. I thought that they were recruiting somebody who was going to take a university, very large, in a university practice in the poorest neighborhood in Chicago, the South Side, and turn it into a patient-focused system. Wrong. 6 years I tried to get them just to have a human being answer the telephone. Well, what do you mean? I mean, we got a phone tree. Excuse me. You got some mother whose pediatrician just told her that the kid's got a heart murmur. It's probably nothing, but she thinks the kid's going to die, right? She wants to talk to a human. She wants to see a doctor, and our wait time was like 6 weeks or 8 weeks before we can get a kid in. Okay, I want to have night hours. No, you can't. We don't want to pay the nurses overtime, et cetera, et cetera. My point is, this was a real shock to me at my personal failure to even nudge the system toward a patient-centric, we are in charge. We, the doctors, are in charge rather than the bureaucrats who run the system. I'll just do my talk now. Okay, what we're going to do today is I'm going to talk a little bit about healthcare as though it were a patient. The system is a patient. So we're going to talk about the symptoms. We're going to talk about the etiology of disease, or in management circles called root cause. We're going to talk about not fixing the patient, because that's their sort of code for getting away with something, ameliorating the patient, palliating the patient, sedating the patient, but not actually curing the patient or whatever the patient's got. I'm going to mention my radical idea called states care, which we're going to talk about in a second. And then I'll talk about what I think we should do here in Texas. Okay, patient healthcare has the following symptoms. In the medical world, Wait times, as you probably know, are up and up and up, and they almost doubled as a result of Obamacare. The acceptance rate for new Medicaid patients is down to 47% in the state of Texas. That's less than half of our physicians can afford to accept Medicaid patients. Doctor shortage is both true. It is a maldistribution as well as an absolute shortage. We, an 18% drop in medical applications to U.S. medical schools in the last 20 years. Okay, last time I talked to a colleague of mine, he said we have 120 slots in the United States for training in cardiac surgery, and we can only fill 70 of them. I don't need to tell you what's going on. And then, of course, we add the insurance companies who are constantly restricting their panels. So from the patient's standpoint, I can no longer see my doctor because my doctor's not on that panel anymore. Or they said he was, but she isn't anymore. Then we got death by queuing. People know what this is. If you don't, you absolutely have to, because it's not just a problem in United Kingdom or in Canada. It's a problem right here. There was a recent, it was 3 years ago, VA report that said, and I quote, 307,000 U.S. veterans may have died waiting for availability of care. In other words, it was potentially possible to do something for the patient, and the patient's standing waiting in line and dies while waiting to get care we could have provided. That's going on today. That's going on in Medicaid. There's data I can show you that as well from Illinois. Okay, those are the medical symptoms. Fiscal symptoms. In 1960, the United States spent 5% of its GDP on health care. Last year, 17, we spent 18 point something percent, and it will probably be 20% of our GDP on health care. Premiums, as you know, have doubled or more than doubled, depending on where you are and a lot of other factors. It was unaffordable before the Affordable Care Act, and now I know it's bad English, but it's more unaffordable. Okay, less affordable, whatever. Okay. I wanted to make the comment, this is real data. $25,864, it was the average family of four expenditure on health care in the United States in 2016. The median income in the United States in 2016 was $57,000, and I forget exactly the last three digits. That's 45% of the gross annual income, median annual income for a family of four in the United States. It's beyond insane, okay? I don't know what other word to use. Now, I want to make sure I'm clear and we're all in agreement. There are two health cares. There's health care, one word, which is the system, and there's health care, which is what you do. And make damn sure that we separate that relationship that we have with a patient called health care with this damn system that obstructs us and penalizes us when we're trying to do health care. Okay, and I'm going to talk to you in a minute about two concepts that are in that book: bureaucratic diversion and disconnection. And disconnection is a big fancy word for what you all experience every day, and I'll show you that in a second. And finally, the set of symptoms, what I call mission morph, not morphology, change, okay? Medicaid, 1965. The law says it is to support those, quote, unable to support their medical needs, end quote, and it has been transitioned into, if you're poor, this is an entitlement. No personal responsibility involved. This is a freebie you get from the government. No, it's a freebie you get from the rest of the American people. Because when the government says, oh, we're going to spend government money, where the hell does government money come from? everybody in this room. Now, here's gets more interesting. For this legislation, which I'm going to talk to you about in a second, I read the original Medicaid Act. Section 1801 of the original Medicaid Act is titled, and I quote, "Prohibition against any federal interference." It's the title of the section. And what it says is, we jointly fund it, state and feds, and the states administer it, period. That's what the original law was. Now, everybody in this room knows that's not the way it is, and we can go through a long saga of how it got that way, but frankly, this was intentional takeover by the feds, controlling now 1/6 of our economy, healthcare. And the other thing I wanted to mention is Medicare. What's Medicare? Medicare, basically, the promise is, the details are obviously very important, but the promise is, in your golden years, we will take care, it's a savings account you put into the Medicare trust over 40 years of working, and then in your golden years, we're going to take care of you and cover your medical needs. Well, what's one thing that's virtually guaranteed if you live long enough in your golden years? It's nursing care. So what doesn't Medicare cover? Now, I'd love to stand up and debate anybody who wants to defend that, because it makes no logical sense. That's why so many of the people on Medicaid support in the state of Texas and everywhere else are actually Medicare-aged people who need nursing care. Okay, now, maybe Jeremy's too young, but some of the people in this room are old enough to remember A is to B as C is to D. Remember this stuff? And we had in our exams, and we were taught in grade school, right? Okay, well, I had, sorry, I may be taking too long, but when I became the chief of cardiology at U of C, I had all this knowledge of academic things and teaching, and I was really pretty good with the kids, not so much with their parents, but with the kids, I was really good. Okay. Then I became chief, and it took me about a year to figure out I didn't know what the hell I was doing as a manager, a leader, responsible for a budget between $15 and $20 million, and they'd show me these forms, and I didn't know what the hell how to read them or what. So I went to back and I got my MBA. I got one really important observation that I want to share with you, which is there is a thing called systems theory, which is basically the management tool to approach a system that is not functional, that is dysfunctional, and help it become functional. Now, you change the word dysfunctional to sick, and change the word system to patient, and to me, I learned that systems theory is to a sick system like healthcare, just the way practicing good medicine is. That's the way you approach a sick system like healthcare. For example, you do a history, you take a history, you do a physical exam, you ask the patient, what's your chief complaint? And listen to what the patient says. And then you sit down and try and develop a differential diagnosis. Then you go and read the literature and say, what's the past experience with these various things? And you come up with the single root cause diagnosis. And then you begin to treat that. That's what everybody in this room does with every patient that we see. But it's not the way they do it with healthcare. So I said, okay, then I should do that with healthcare, because maybe I could figure out what the heck is really wrong with it. So I just looked at it as a patient, and that's that book that's called The Cancer in the American Healthcare System, which is there. Now, this again is so obvious to everybody in this room, but apparently our people in Congress don't know it. If you want to cure a patient, you address, you treat, you fix the etiology of his disease. You don't just put a Band-Aid on a patient who's got a diabetic ulcer. You treat his diabetes. Well, it's the same thing. If you want to cure a sick system, you have to dissolve, that's a management term, as opposed to solve, dissolve the root cause. So Obviously, you're going to sit here and say, well, okay, what's the root cause? Now, you know what it is, but I'm going to say it anyway. The etiology of patient health care's illness is two things, although they're really sort of the same in essence. Federal control, government control, administrative state control, call it whatever you like, along with the third-party payer structure. Now, the third-party payer is the key element in here, and I want to go through that with you right now. Oh, no, I wanted to show you this. That's per capita spending, us versus a whole bunch of European countries, Sweden, the OECD. We all started in the same spot in 1970, give or take a few dollars. Look at what's happened in 40 years. And oh, by the way, it is now, do the math, if we spend, which we did in 2017, $3.4 trillion on healthcare in the United States, and we have 323 million Americans, do the math. That's a little over $10,000 for every man, woman, and child in this country. Okay, bureaucratic diversion, a nice fancy word for theft. Okay. The truck rolls up, and it's got $3.4 trillion in bags of money. Now, that's your money to pay for your care, right? Where'd they get the money? They got the money from your taxes, not to mention the money they printed, which, of course, is dead on our children. But be that as it may, the truck rolls up, and it's got all these bags of money, and who takes the first biggest bite by far? The government, the administrative state, call it whatever you want, and then the whole corporate structure, and what's left is what you get paid. Or, no, let's rephrase that. What's left is what is available for patient care. It's an afterthought. And it's, oh, well, you know, they're going to have to deal with the leftovers. It's what I call bureaucratic diversion. I actually call it theft in my talks, but editors didn't like that, so I changed it. Why is the U.S. overspending? You saw that graph before, $3.4 trillion, and yet there's no money for you guys. In other words, where is all that money going? Who's seen this graph besides me? Okay, think about it for a second. The blue line, for those of you who don't know on the bottom, that's the growth of the supply of physicians in that 40-year period from 17 to 2010. The astronomical thing that's growing is bureaucrats. I did this list because I wanted to make you think about it. Actuaries, accountants, administrators, billers, and coders, the third largest division in every major medical center. Nurses are first, in terms of numbers. Nurses are first, doctors are second, and the third one is billing and coding. In my view, a completely unnecessary system if you had the patient and the doctor connected to each other by a bill for services rendered. Anyway, I'm sure you guys could come up with more on that list, but that was the list. And notice, by the way, I did this so I wouldn't forget to tell you, that stopped at 2010 before they implemented Obamacare. According to my calculations, Obamacare added 454,000 administrative jobs to the United States. Hello, guys. There are only about 1 million of us, and they just added 50% more of people who don't provide any care. But the system has to pay their salaries and bonuses and whatever. Okay, you can keep changing every time I say federal government. If you want to say administrative state, if you want to say bureaucracy, that's fine. As far as I'm concerned, they are one and the same. Its primary tactic, and here we go, I'm about to reiterate my colleague's remark, their primary tactic is complexity. Now, who has seen this one? Have you? Yeah. You know who did that, by the way? Who did the graph was Kevin Brady, Texas 8th District in Congress, told his staff about April of 2010. It was signed on March 23rd of April of 2010. He said, I want to see an organizational chart of Obamacare.
Where are the patients?
Think about it. All of those circles and boxes are organizational charts, each of which have layers of circles and boxes, because we've all seen organization charts, and every one of those circles and boxes has got people in it, and somebody has to pay them. That's where that previous graph makes perfect sense. When you look at this, they made it intentionally complex in order for us, where is it, John? In order for us, the doctors, to need them to navigate the system. As a matter of fact, in case you didn't know it, the Obamacare rules and regs require every state to hire navigators, that's their title, to navigate the people through the insurance system. Now, there's an engineer in the back, right? Okay. What is the definition of a good design? They call it, sorry?
It's a job creation.
450,000. You got that right.
Regulation of economy.
Yes, unfortunately, they are jobs that you pay for that are worthless. The engineers, if you look at a fine design of something, a car or a submarine or whatever, they call it elegant when the thing is just designed so that it's easy to work, that you can easily repair it, and that the users find it easy to use. You mean our children are going to have to pay for it? Okay, now, I show the next slide mostly to not physician people because they don't know it. I'm showing it to you just to get a laugh, okay? Nobody knows what I'm going to show, but you're going to get a laugh in a second. All right, complexity in action causes the massive, unnecessary regulatory burden, wasteful government, dollar inefficiency. Dollar inefficiency, make sure you're clear on that. Another thing I learned in my MBA. Dollar efficiency, not in, dollar efficiency is the number of dollars that go into the system that produce the outcome that you want. All right, the healthcare is the system. The numbers of dollars that go into it are 3.4 trillion last year. And what is supposed to come out of it is healthy Americans. And the way you get healthy Americans is providing care to them. So the question is, how efficient or inefficient is healthcare? And the answer is, before Obamacare, my calculations in the book, my calculations show it was at least 40% inefficient. That is 40% of that $3.4 trillion went to the bureaucrats, that organizational chart, compliance officers, review processes that don't give a darn about what the patient is. It's only whether you follow the regulations. So just, okay, folks, ICD, remember ICD-9, now ICD-10? ICD-9 had 13,000 codes. ICD-10, oh, it's a massive improvement. It has 68,000 codes. I did this. If you take Cecil's textbook of medicine and you count the number of illnesses that affect humans, they're around 1,400. We got 68,000 codes. Now, has anybody read this? Your billing system has. Okay, I read it, or at least some of it. You're ready for a laugh? Okay, we got bitten by a cow. How about pecked by a chicken? Pedestrian on foot, injured in collision with a rollerblader. We needed to know this because, okay, now, injured at the opera. My personal favorite is injured at a swimming pool within a prison. Okay, and then of course, finally, You got problems with your in-laws? Well, that's 063.1. That's a billing code. Now, think about it. That's just an open invitation for abuse, fraud, waste. But the thing that people don't talk about is error, which is possibly, the data is really weak, is possibly the major cause of billing mistakes is well, you thought you did it right and followed the rules, but the rules are, you got to read some of these rules to see all the exceptions. I mean, I read some of them and it made me absolutely crazy. If you have trouble sleeping, you just read the ICD-10 codebook rules.
You want to kill yourself.
Well, then you might take a gun, but you would probably take a gun, I hope, to a bureaucrat, not to, okay. So, this is one of my favorites. I'm going to give you the doctor's perspective and end with the patient's perspective, okay? So, the doctor, well, you got to get paid, so you have to do all these things, says the payer, right? It's not the patient, it's the payer, okay? You need to carry these manuals with you. Of course, the regulator says you got to do X, Y, and Z. You must protect your patient's medical records. Of course, so secure that we can't talk to each other. I'm not allowed to send my consults through email because they're not secure, but the U.S. Mail Service is, okay. Okay, let's keep going. Now you got the government keeping track. I mean, you know the forms you fill out. By the way, the number one complaint that I have heard as I've gone around asking people, because I'm on the health exchange board for the state of New Mexico, and I'm asking people, you know, what are your concerns and so forth. The number one concern, by far, is when I finally get in to see the doctor doesn't even look at me. He's spending all of his time looking at a computer screen. Okay, federal regs require it. Then you got the lawyers watching out for, remember that every adverse impact is your fault. You know, if you give somebody a drug that is 85% effective, 10% really doesn't help the patient much, and 5% it actually could have an adverse impact, how do you know whether patient X is in group 1, group 2, or group 3? You don't. You're playing the odds. But if the patient has an adverse impact, it's your fault. And then finally, we've got David Brailer, you know him. He, very fine physician, et cetera, et cetera. This is the Bush administration. They gave him the authority to create a national medical information system. And he had money, and he had this title and whatever. And about a year and a half into it, he quit. He said, "You're making me do it within the federal regs rather than doing what the physicians and the patients need. And I can't do it." Then we got the patient's perspective, which basically says, okay, get up. I need medical care. Well, I don't have time for you. I'm filling out the billing and coding, and I'm following the regs. And by the way, the original name for the Affordable Care Act, it's had 4 different name changes before. It was House Resolution 3590. So that's why I put in the original name in there, just for be cute. All right, now disconnection. This is really important, and it's, again, something you all know because you experience it every day. You got a buyer and a seller, which is the same thing as saying you got a patient and a provider, okay? It could be a doctor, it could be a therapist, it could be a nurse, but the bottom line is one's buying and one's selling. That's the way it is when you go buy a car, when you go buy a sweater, when you go talk to a lawyer. You're getting legal services, right? You go talk to them. He gives you your will. You pay him money, and that's the end of that. Not in healthcare. In healthcare, the buyer and seller, AKA patient and doctor, are separated by a third party. Now, we can argue about who's worse, whether it's the government or the private insurance companies, but since the government basically works through the private insurance companies, to me it's pretty much all the same. And here's the key. The two basic free market forces that make any market work. I mean, a free market, we all know, is the best way to get the most goods at the best quality at the lowest price to the most people. You know, how many examples do you want to spend talking about? That's been shown over and over and over again. The two basic forces that accomplish that are the incentive to economize and the sellers competing for the buyer's decision to buy or not to buy. But the trouble is that a third party destroys both of those, or interrupts or disrupts, or whatever word you want to use, the market forces. And so here's one that I originally had his teeth sharp, like, you know, okay. And the artist that did this is from Restoring Care to American Healthcare, which is an ebook series that you really should read. It's cheap, it's $4, whatever. He said, you know, you're going a little too far, because they literally, I had these sharp incisors in there. So let's get to the cure. We all know the symptoms. We all know the root cause. The administrative state, the federal government, call it what you will, with a third-party payer structure. So how are we going to cure the patient? Well, fairly obviously, if the root cause is Washington controlling, and now we're getting to sort of my focus, which is Texas, okay, because bluntly, I'm not confident that we're going to have any real impact, anybody is going to have any real impact on Congress. Now, I think President Trump is moving in the right direction with what he can do, but in contrast to his predecessor, let's give him a special credit for this. In contrast to his predecessor, he is using executive orders where it's legal to use executive orders, and his predecessor used, King v. Burwell, used executive orders where he did not have the authority or the legal right to do so. And so there's only so much that the president can do by executive order. It has to be Congress that deals with this mess. And Congress, sorry to agree with you, Congress ain't going to do it, okay? They've got too much of a vested interest in 1/6 of our economy, in all of these votes that they are consumed by giving promises that they won't deliver. Okay, be that as it may. So the cure is fairly obvious, which is we need to take back control. Now, the we in that ought to be the patients. And the trouble is you can't do that, just say, okay, we're going to blow up the whole system and we're not going to have a system. So what I am really pushing is what I call states care. To make the joke of Obamacare or Hillary care or whatever. Let's call it states care. What do I mean? It's really simple. Feds out of healthcare. California, you want a single payer? Great. Do it. It's not my problem. Let's talk for a second about the 10th Amendment. I'm going to mention that later on in the last slide, but everybody knows the 10th Amendment, right? The 10th Amendment clearly did not enumerate health care as a federal responsibility. And I've heard people argue with me saying, well, you know, they just missed it and healthcare wasn't that big a deal back in those days. Excuse me, 5 of the signatories for the Declaration of Independence were physicians, something like 17 or 20 some number, but some larger number were delegates to the Constitutional Convention. These are all physicians. Now, okay, fine, they didn't have antibiotics and they didn't do open heart surgery on babies, but they were still doctors and they were still trying to take care of patients, and they still believed in the same ethos that you and I believe in. So the fact that they didn't enumerate it was not an oversight. It's not the federal government's responsibility. So I would respectfully argue, if California wants to tax its citizens and create a single payer system, fine. We know that it will collapse. But that's their problem. That's their choice. That's their right. under the Constitution. Here, we recommend a different system, and it's your system. It's called get Washington out of Texas healthcare, A. B, 10th Amendment, as I said. Then number 3, Texas, doesn't have any control over health care for 29 million Texans. It's basically federal law. We do have, in theory, control over 4.4 million Texans under Medicaid. I propose that we start with the hardest population to deal with and create a demonstration project. Those of you who know the term Section 1115 waiver, which everybody's talking about, work requirements, which I happen to think is a very good thing because it's personal responsibility. Be that as it may, the title of an 1115 waiver under the Medicaid law is as a, quote, demonstration project. Namely, you got a different way to do things. We're going to waive the regulations for you for 5 years for the sake of argument, and you go do your thing, and let's see what you demonstrate. So I say, okay, let Texas demonstrate that a free market or a market-based system actually works, and it works in the hardest population to take care of, which is the Medicaid population. Although you might argue that the old age Medicare might be the hardest, but won't go there right now. I just call it Texas Cares to keep up with States Care, then we'll call it Texas Cares. So what is it? Okay, large HSAs jointly funded by the individual. You can't get money if you don't put some of your own in there in the first place. A time limit on support, declining over, the state decides how many years, 4 years, 6 years, or whatever, the money goes into an HSA. High deductible, if you will, catastrophic insurance. No rules or regs. No rules or regs. The bureaucratic cost of this, if you think about the amount of money we spend on compliance and billing and coding and all this sort of stuff, all of that goes away. And so what you end up with is 4 million or so Texans who have large HSAs, and they have to shop for their care. And you all have to compete for their dollars, period. End of story. And I was going to end this with this. You can call it a form of direct pay if you like. You can call it cash only. You can call it private practice of medicine. And I was sort of done with this little box, and then I realized, no, my grandfather would simply say, that's just being a doctor. That's the way you practice medicine. I remember, I must have been 4 years old, 5 years old, crawling around in my grandfather's office. Of course, HIPAA now would, give him all sorts of problems. But okay, I remember crawling around there and watching him interact with the patients. And I remember seeing people, when they're done, they go to the receptionist, who was often my grandmother, and would take out their wallets. And they give them $2 or $3 or whatever. And I didn't understand this. I just watched this experience. Okay, fast forward to about 35 years. I'm in private practice for 2 years. Who was it? It was you. In private practice for 2 years before the first time my receptionist came into the back of my private office in the back and said, Dr. Waldman, I don't know what to do. What? The patient wants to pay in cash. 2 years before anybody took out their wallet and paid me money. Okay? It happens to have been a rich, my bills for pediatric cardiology, my bills are really high. So, frankly, even if you're fairly comfortable, you're going to have to think twice about paying my bills because I'm expensive. He had this roll of $100 bills. and he knew that his child was going to need surgery and we were going to do this and that. And so he brought this roll, and now his kid's fine and we're discharging him, whatever, and he wants to pay. And he just pulled out this roll of $100 bills and said, "How much?" So I was really good. I said to her, calmly, I said to her, "Take his money, give him a bill that says paid in full, and then put it in a cash drawer." She said, "We don't have a cash drawer." All right, I'm going to leave you with this. This is also from one of the ebooks. I wanted to emphasize that book that I mentioned earlier about Johann Peter Strauss and the medical police and so forth. At the end of the day, the patients have to decide whether they want the empty promise of entitlement, or whether they want to take responsibility for themselves and work with us for their health and accept that our work is a work product, not their right. And that's where I am.